considerably more time. But I am going to take a deeper dive today, specifically in the ACI category. I know a lot of you, 67% of you are on varying EHRs, and I know that a lot of the software itself isn't ready yet to implement some of those metrics. That was one of the reasons for that question. I was just curious to see how the industry was doing as far as rolling out all of the requirements in the software that were going to allow you to sort of track those numbers. So with Stacey's intro, let's go ahead and hop right in here. All right, so the agenda for today, like I said, I'm going to do just a brief overview of MIPS, just for those of you who might have missed the first webinar. But we're going to definitely dig into the meaningful use, which is now the ACI category. We'll talk a little bit about who's eligible, different groups, et cetera, how you participate. So, what is it that you're going to need to do to get yourself ready? What is it that you're going to look at and track throughout these reporting periods? Determining your reporting period is a big step in and of itself. Are you going to do 90 days? Are you going to simply report, the whole year? If you've been successful in meaningful use in PQRS in the past, meaningful use specifically, I would highly recommend that you just keep doing what you're doing for those of you who haven't had your dashboards rolled out yet, because as you have probably already noticed, it's basically all of the measures that you were doing successfully in the past is essentially what the ACI category is. In fact, CMS has really tried to make it easier, even by taking away a lot of the thresholds and simply making it yes or no, or by giving you the option to sort of pick and choose your own threshold. And we're going to go through all of that as we move through the presentation. We'll talk a little bit about scoring. Scoring can be slightly confusing, especially when you throw in all the other categories. That's why I like to kind of break it down in chunks. And then finally, we can follow up or end with any opportunities or questions that you may have and how we can help you navigate through this process. So just really briefly, just as a very high-level overview, you all know what the Quality Payment Program is, and I'm sure you're all aware that there's two paths. The goal of it is, Medicare is trying to reform how care is given across the entire, healthcare continuum. They're really looking to move toward value-based care and away from fee-for-service. I think that MIPS is sort of the lead-in into this value-based care, whereas the advanced APM, the APM track, is for those people who have always sort of been at the leading edge of this process, and they're already participating in APMs, and now they're looking to extend that down into more advanced models. There are about 6 of those available now. I'm not sure how many of these people on the call are actually going down that track, but we're going to focus specifically on the MIPS track and even more specifically on the ACI today. And so we all know what MIPS is. It's basically all of the acronyms you've done in the past, PQRS, the value-based modifier, any of the EHR incentive programs like meaningful use. All of these things are not going away. They're just being rolled into what is called MIPS. So the legacy program phase out was done in 2016, which you guys are all aware. That was the last time you could submit or attest. And then the PQRS payments will end in 2018 for those of you that are still either receiving those or anticipate that. So eligible clinicians for MIPS. This is Medicare Part B clinicians billing more than $30,000 a year and providing care for more than 100 Medicare patients a year. So it's got to be both. MIPS is a little bit more inclusive, I think, of different types of clinicians, a little more flexible. It includes not physicians, but this time, whereas meaningful use didn't, it includes the physician assistants, it includes nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. They are all eligible for participating in MIPS. And this is important to note, especially for groups that do employ a lot of mid-level clinicians, because now with it being sort of an all or nothing thing, especially if you're a group, they're going to have to submit their numbers as well. So it's just something to think about for someone who's never had to do that in the past. And just a quick tip, this can be DOs. Believe it or not, now it's open to dental surgeons, chiropractic. I think chiropractors, it's kind of state specific. I've heard a couple of different things about chiropractors, so don't quote me on that, but I'm pretty sure that most states can do that. Even non-patient facing clinicians can do this. I've had a couple of questions about this, so I thought I would just point it out. They are eligible to participate as long as they exceed the low volume thresholds that we just mentioned. They're not newly enrolled and are not already participating in an APM or a partial QP, which is someone that's in an APM that's also advancing toward an AAPM. There's some different rules regarding that. The non-patient-facing eligible clinician threshold for individual MIPS eligible clinicians is less than 100 patient-facing encounters in a designated period. Sorry, I got a little, that was a tough sentence. A group is non-patient-facing if 75% of the NPIs that bill under that group 10 during any reporting period are labeled as non-patient-facing. So, and I don't want to go too deeply into this because there are a lot of different requirements for this. I just want to make it known so that if you are in that population or you have a practice or know one, there are, if you go on the CMS website, there are specific rules for patient-facing clinicians. So the performance categories, like I said, I'm not going to go into each one of those today. I did that last month at our overview presentation. But all of these categories combined is moving, like I mentioned, to a performance-based system and away from fee-for-service. The good thing about MIPS, I think, as opposed to MU and PQRS in the past, it gives the clinicians more flexibility. So it gives you more options to pick things that are actually appropriate for your practice. I know with meaningful use, a lot of times you were asked to report on data that is not typical of your practice or it was very difficult to obtain from patients. So I do think that the CMS has tried to make it a lot more flexible so that you can actually do this in a more meaningful way. Not that meaningful use wasn't meaningful, but I did find a little bit of irony in that because I do feel like they've realized that it does need to be even more meaningful than it has been in the past. And wherever possible, because the overarching goal here, like I said, is to have everyone move toward an advanced APM in the long run. This is sort of your stepping stone. But they've aligned a lot of the reporting requirements, which you'll see when we talk about some of the improvement activities for ACI here in just a minute. They've really tried to align those with what the advanced APMs are doing, so that it makes a nice, easier segue into those more complex programs. All right, so for 2017, so we've already the clock is already ticking. You have a few options. You can participate in the advanced alternative payment model, and if that's the case, you're probably not going to be on this call. The test pace is what a lot of practices, especially ones that haven't done well in the past with meaningful use, submit some data, right? So you can just pick a quality measure and submit that anytime after January 1st, right? So that will probably be that's the best way to avoid a negative payment adjustment. However, I would not get my hopes up for any type of positive payment adjustment because there's just going to be a lot of other practices out there who are doing much better than that, and they're going to fall sort of at the higher end of that spectrum. And we're going to look at that scale too. The partial year, any 90-day period you can pick, as long as you can report for those 90 days positively, you should be in a good position to at least to get a small positive payment adjustment, but most importantly, still avoiding that negative 4% payment adjustment. If you do the full year, I think those are probably the ones that are going to get the most bang for their buck as far as the payment adjustments on the positive end. If your data quality is good, especially, and your numbers are way up there, you fall in the higher end of that bell curve, that you've set yourself up for the most potential in earning the highest possible incentive. But in the red, just the takeaway from this slide is, obviously doing nothing will get you a 4% negative payment adjustment. And I don't know what your Medicare collections are on an annual basis. For some of you, though, that could be a very hefty penalty. So with us being almost in June, if you haven't started, it's definitely time to get in gear. So this scale looks kind of complicated, and what it amounts to is it basically just shows you how the money is going to be dispersed. There's $500 million that CMS has set aside for those high performers. And what that means is over on the left, you're going to have all 4 of your categories, which is your quality, your cost, your ACI, which caveat, cost is not being factored for 2017. I'm sure you guys are aware of that, but just in case. Your ACI score and your improvement activity score. All of those are going to give you your final performance score. If your final score is above the benchmark, it's above the benchmark, then that automatically kicks you into a positive payment adjustment bucket. But depending on that distribution, that it could get you upwards of 3 times. But on the flip side, if you fall below the final score at threshold being 0%, right there on the line, tied to average performance, which is your benchmark, if you fall there, you're going to break even, okay? If you fall below it, then you're subject to the plus or minus the 4%. So you can see it's kind of it's a spectrum, and wherever you land on that spectrum is based on how well you do in the 4 categories. So it would definitely behoove you to not fail something as simple as, I feel like, the ACI category. That's 25 points, 25% of your total score. It's an all or nothing thing. If you do part of the ACI, you're not going to get 22 points. You get 0. So right there, you have really kind of dampened your hopes of getting any type of positive payment adjustment. So this just kind of puts a little more numbers on it, basically. That was sort of the model that CMS uses, and this is just to kind of really hit home what you report on, how many elements you report on, what your performance score is. All of these things will help you go further up that arrow. Additionally, how well you do on those left-hand categories, those boxes of MIPS, those go together to land you somewhere along that line, that continuum. Obviously, the higher score, the higher you're going to be on the arrow, the higher your chances are of sharing in more of that money that CMS is offering. No data reported. Once again, I can't stress this enough. If you don't do anything this year, you will have a penalty in 2019. There are a couple of exclusions for MIPS. I just like to point these out. If you're newly enrolled for Medicare, you're a new clinician perhaps, you're exempt for the first year. Okay, so if you just got out of residency or what have you, or just started accepting Medicare patients, then you're exempt. Obviously, if you fall below the low volume threshold, which is less than 30,000 and fewer than 100 Medicare patients, you're exempt. And then if you're already participating in the advanced APM track, you do not have to participate in MIPS. You're automatically qualified for a 5% bonus, completely irregardless of MIPS. All right, so I'll just like some more FYIs about meaningful use as we transition into MIPS and the ACI component. Providers who have previously attested for MU through Medicare before will not participate in meaningful use since they're now going to fall into MIPS. I think that kind of goes without saying. Providers who attested Medicaid but also bill Medicare can additionally still attest for Medicaid for any of those remaining incentive payments. And I've had a lot of questions about that. So you can go ahead and still participate in Medicaid. Providers who have not participated in MU previously are required to participate in both MACRA and MU for 90 days and reported by October 1st to avoid the 2018 penalty. And this is a little bit more Medicaid specific. I'm not sure how many people on the call really have a lot of Medicaid population, but I will go ahead and mention it. All Medicaid providers will attest to a 90-day EHR reporting period for this year for MU. The second or later reporting year reports, you're going to do the full year of clinical quality measures. You can attest after January, but anytime before, obviously, March 31st, that first quarter of 2018. But just bear in mind that the measures now, there are no alternative exclusions, and all actions must take place during the program year. So for you, those of you who are familiar with that, that will probably make a little more sense to you. If you're not, then you're probably not seeing a lot of those patients. So hardship, I get lots of questions about this too. If you did not successfully meet MU last year and you want to apply for a hardship exception, you have to submit it no later than this July 1st of 2017. Now, once again, if you're newly enrolled to Medicare, you're going to receive an exemption, and you don't have to fill out the form. But if you are interested in that, if you go on the CMS website and just type in hardship into the search box, it will bring up the 2 forms that you need to fill out to successfully apply for a hardship. Something I do want to point out, and I'm not sure how many people are aware, that you can, going forward with MIPS, you can only do hardship for 5 years. So if you've been sort of rolling through this meaningful use era with hardship, that will come to an end. So make sure that you're at least got your wheels in motion to get a plan in place for that. All right, now let's talk a little bit about the ACI category itself. So as I mentioned, it's worth 25% of the total score. Now, these are the default weights. I've got a slide in here a little bit about the fact that weights can be adjusted in certain circumstances. For instance, if you're hospital-based mostly, or if there's just unforeseen circumstances that you just you're not able to complete the ACI, you can get your ACI percentages moved over to quality, and we'll look at that. So the performance category itself, it's made up of 3 buckets, basically. It has a 155% maximum score, which we capped at 100. And the reason they do this is really to allow you flexibility. It gives you more opportunity to pick, as I mentioned, the measures that are more applicable to your practice and more obtainable. So you can really kind of focus in on those that you actually think you could implement in your practice and not worry about maybe one that you know that you're never going to get above 2%. So the first bucket is the required base score, and that's worth 50% of your ACI score, which is 25%. All right, sounds a little confusing. Well, we're going to talk through it. 50% is base, and all of the measures that are in the base score are required, but there's very few of them, and they're basically, it's a one patient numerator. If you do any of these things for one patient, or you do your security risk analysis and you attest yes, you have earned your 50%. But you have to do all of them. If you don't, you will get 0%. The performance score, this is basically the meaningful use objective. So these are the things that you've been doing in the past for meaningful use. And if you've done them well, like I said earlier, just keep doing them, because this is how, work on getting your numbers high. Because we're going to look at how much these points or these numerators and denominators are now worth. These thresholds have points attached to them. So that's going to be the middle bucket. Now, the last bucket is your bonus score bucket. It's worth up to 15%, and this is all of your public health reporting. It's also submitting some improvement activities through your certified EHR, and that can be in and of itself worth up to 10%. So we're gonna walk through an example here, which will make this a little easier. I mentioned reweighing. So providers do have certain issues beyond their control, like face-to-face patient interactions, or like I said, if you're in the hospital a lot, you can have the opportunity to apply for your measures to be reweighted to the quality category. CMS will do this, for you, but you have to let them know. And what hospital-based really means is that 75% or more of the Medicare services that you're doing in the inpatient on-campus department or emergency department. So if you're not doing these, if you're doing 75% or more of your procedures and patient care anywhere but in the office, then you can have your ACI reweighted, and then you won't have to submit those measures. The quality requirement would go from 60 to 85% though, so bear that in mind too. So whatever you have been doing in the past, essentially for PQRS, that's going to be a lot more important if you're shifting that weight over to the quality category. All right, so now let's talk about that first bucket, the base score. All right, so there's 2 columns here, and that's because the measures that you will submit are based on your EHR. So if you have an EHR that's certified to 2014 through the ONC as being a certified EHR, you're going to use the transition objectives and measures. If you have an ONC certified to 2015 EHR, you're going to use the left-hand side. So the reason that is because a lot of softwares had not actually built out these requirements on the left side to make it possible for providers to collect that information. So in order to help those practices sort of segue into the MIPS program, they created the transitions objectives and measures, which has a couple less of the requirements that their EHRs are just frankly not capable of doing. They will eventually get there. They are going to have to certify for 2015, but CMS is cutting all the vendors a break basically this year and saying, okay, here's here's the 4 that we'll have you guys do since we know your EHRs can't do this yet. So the ones I mentioned were the security risk analysis. That's simply a yes, no. You do it, get it done. And, you know, sometimes people don't think about that, or they kind of let it fall by the wayside a little bit. And you can't do that because, like I said, this is all or nothing. So if you do all of these other things, which you probably already have built into your workflow, for one patient, that's all you have to do to pass. But if you forget to do that security risk analysis, you know, maybe have your IT guy at least be thinking about that or have it in the front of his brain. Because if you don't do that, you'll fail. E-prescribing, most of you are already doing that for meaningful use. Provide patient access. I know most of you probably have a portal. A summary of care, and request and accept a summary of care. So you're going to want to get that summary of care from another provider. You guys have already been doing this. The beauty of this now is that you only have to do it for one patient. You don't have to make a 70, 80% threshold, 50%, whatever the case may be. So that in and of itself is a nice break. Same thing for the transition objectives on the right. Now here, this is the second bucket, the performance score. So these are essentially all the other meaningful use measures. Okay, patient electronic access, patient specific education, secure messaging, HIE, MedRec, public health reporting. So the nice thing here is that if you're not doing so well in one of these, I know I have a lot of clients that, you know, they struggle with the HIE because maybe, you know, other providers out there don't have direct messaging yet, or they don't have the capabilities for that. So they really struggle with, they couldn't even get the 10% that they needed last year. So what CMS has done this year is they said, okay, focus on the ones that you do. You know, do them all, obviously. We're not going to require a certain percentage of threshold from you. However, what we're going to do is if your thresholds are high, we're going to give you extra points for that in essence. So for example, if a physician submits a numerator and denominator of 85 for patient-specific education, that means their performance rate is 85%. So if you look over to the column in the right, that 81 to 90, they're going to get 9 out of 10 percentage points of that measure. So the better you do, the higher the thresholds are, the better your overall performance score is going to be. And I'm going to show you an example of that, which makes a little more sense. And then finally, that third bucket is the public health reporting. Okay, so 5% of that public health reporting is if you choose to report on, you need to do at least 2. One of the following. So syndromic surveillance reporting. I know a lot of states aren't actually offering that. In fact, Florida, which is where I'm located, does not offer that. So we're not eligible to participate in that particular one. Specialized registry reporting, electronic case reporting, any public health registry reporting, and a clinical data registry reporting. Any of those options, if you pick 2 of those, can earn you a 5% bonus, which will go into your final ACI score. A 10% bonus is for using your certified EHR to report certain improvement activities. We'll take a look at those next. So just to go over the public health reporting, this involves immunization reporting, syndromic surveillance, and specialized registry, which I mentioned. All providers must attest to 2 measures, which I mentioned, but they may report to more than 1 specialized registry to meet the required number of measures for the objective. Each provider must be in active engagement with the public health agency to submit this data. They must register intent with each within 60 days of the start of their reporting period, and they have to respond. So what this means essentially is that you can't just sign up for one of these registries that's out there. You actually have to engage. You have to submit data. You have to create your logins and check in and use it for what it's meant to be used for. I have an example on the next slide. And this, like I said, I'm in Florida, so this is obviously going to be my go-to. Florida has the Florida Cancer Registry, which a lot of my clients use. And then they also have another public health specialized registry called eForce. So this is for controlled substance monitoring. So what they have to do is, like I said, they can't just sign up for it. They actually have to go, and now some of the softwares have have it built in so that if they go and they log into this eForce and they check to see if, you know, this person has a lot of controlled substances prescribed to them, and then by clicking back into their EHR, that earns them credit for that. So then that way CMS, it's almost like an audit, an internal audit, so to speak. So that way they're actually interacting with this application. Now, I know I mentioned that performance bucket, okay? So there are improvement activities that you can do through your EHR. Oh, this is the bonus bucket. I'm sorry. I apologize. So now what this means is that they're weighted. Now, if you go on to CMS, they have a specification sheet that you can download that will actually tell you what the definitions of these activities are and what it takes in order to attest to them through your EHR. So a lot of these are obviously going to require some workflow changes, and a lot of these are probably things that you're already doing today, especially for those of you who are perhaps a PCMH or, you know, participating in any other type of value-based programs, either through private payers. A lot of these are the same types of requirements for those programs. But what they're going to want you to do is pick a few of these things that you think you could work on realistically, and you're going to have to attest to them through your EHR. This is not the QI. This is not the quality improvement activities or improvement activities bucket of MIPS. This is specific to ACI, so this is where it can kind of get a little confusing. But if you go on to CMS, you can find, like I said, very detailed descriptions of exactly what these entail. On the surface, some of them look pretty easy, but if you look up the requirements, sometimes you may have to make some workflow changes or do some education within your practice. And you may not have these set up at all. This may be, you know, an entire project in and of itself to get these set up. But this goes towards that ACI score, and I'm going to show you some different ways that you can get your 100 points. But I just want you guys to be aware of all the different ways in which you can get there. If you did all of this stuff, you would be at 155 points, which we talked about earlier. You don't need that. You only need 100. But I just want you to be aware that CMS has given you several opportunities and different ways that you can get to 100 points without doing really much extra work than what you've been doing over the past few years. In fact, it may even be a little less work once you get everything set up. So the methodology, which just to kind of review, was that first bucket, which is the base score at 50 points. If you don't do all of it, you get 0. The performance score is 90 points of the 25%. All right. If you do some of it, you're going to get some points. Okay. The bonus point is what we talked about with the public health reporting and the improvement activities through your EHR. So you can get up to 15 bonus points there. So 100 or more points, and you're going to get your full 25% in the ACI category. All right. For example, and this kind of helps break it down. Sometimes it's hard to wrap your head around all that. If you do the base med score, right? You did the risk analysis, yes. E-prescribing, you've got your numerators and denominators. Provide patient access. All of your numbers are there. And remember, you only needed to do one patient. So you've done everything you need to do. So you've got your base score of 50%. Now let's look at the performance category. So the measure, provide patient access. You got 250 out of 500. So your performance rate is 50%. Based on that right-hand chart we looked at on the previous slide, that tells you how many points you kind of get for where your thresholds fall in that range. All right, patient-specific education, 3%. Okay, well, they got 1%. So you see how this works. So at the end of their reporting period, based on all their numerators and denominators, they had a performance rate of 37%. Because those are the points they got for all of their thresholds. So now you see why thresholds are very important, because the higher your threshold, the higher your performance category. So what this could possibly mean is that it's just one less thing if you fail, let's even say that you failed the base score, which I would not recommend doing, but let's just say that you did. You could almost make up for it through the performance and the bonus category. But like I said, I don't recommend that in any way, shape, or form. But you can see now, if you do your base score and you do pretty well on your performance, it's not going to take very much to get you to 100%. So let's say, for instance, this particular client did do well on the bonus score. Okay, they did report to a specialized registry, and then they're doing some additional public health reporting. Yes, yes. All right, so they got 15% bonus score. So their base score was 50, their performance score was 37, their bonus score was 15, so they got 102%, thereby receiving their 25 points for the ACI category, which I know this is why this is so complex, because this is literally one bucket of your total MIPS score. That's why if you break it down and do it in pieces like this, it makes it a lot easier on yourself, whoever's in charge of doing all this calculation. It makes it easier on the practice too, to understand what their requirements are. So final scoring. All right, so this is for the overall MIPS. So let's say you got your 25 points, or your 25% in the ACI. Now, how well you do in the quality, cost is not a factor this year, and then how well you do on your improvement activities will determine how many total points you have, okay? If you're at or above 70 points, you're more than likely going to get a positive adjustment. I mean, I'm not sure exactly how they're disseminating yet, like I said, because everyone lives in one big bucket. But you're also eligible for an exceptional performance bonus. And what that means that if you're, let's say the benchmark is, most providers are around you regionally, nationally, however CMS, disseminates it, are at 79%, and you scored 89%. Well, guess what? You may fall into the top of that bucket, and you qualify for additional money. So the better you do as a practice, the better your chances are of participating or sharing in some of that money. 4 to 69 points, you may get a positive adjustment. It just kind of depends on how everybody else does around you. So if you know your community and you kind of know your market, you know your peers and how well everyone's doing, that will probably give you a good idea of what you need to do to put yourself in a good position. But you're not going to be eligible for an exceptional performance bonus, which is where those high quality providers are falling. 3 points. So that's if you do one thing. We talked about the test, send something. Send one quality measure, okay? You will avoid, that's worth 3 points. One quality measure is worth 3 points, okay? So you will avoid that negative 4% payment adjustment. But if you fail everything or don't do it, you will get the negative 4% payment adjustment. So 0 points is obviously just not participating. So for group reporting, just to mention, I know a lot of people, some report individually, some are going to be doing this as a group. When you report as a group to the ACI performance category, the group would combine their MIPS eligible conditions performances under one taxpayer identification number. They're not calculated based upon one MIPS eligible conditions performance. If reporting as a group, hospital-based MIPS eligible conditions do not need to be included in the group calculation for the ACI information performance category. That sounds kind of complicated, and it kind of is. So if anyone has any questions, I can sort of talk to you offline about how that works specifically, if you haven't yet got yourself in a position for that. And then there are some changes in the calculations between the Meaningful Use Stage 2 and the ACI program. Inactive and deceased patients no longer excluded. So that's pretty meaningful, I think. Can really affect your numbers. Used to your denominator was automatically decreased. So if you're trying to really work on increasing your threshold, your denominator could be a lot bigger than perhaps you expected it to be based on your past participation. So just make sure, just be mindful of that. I thought that was kind of an interesting caveat. And then only one objective has any exclusionary criteria, which I think is also of note. There used to be a lot more exclusions in a lot of the meaningful use measures that providers could take advantage of, and that's no longer. So the only one that has any exclusionary criteria is e-prescribing. So for providers who write less than 100 prescriptions, obviously that is an automatic exclusion for that reporting period. All right, so that is the only base score objective that's going to have any exclusion. So just make sure you keep that in mind too. If you've used exclusions in the past, you need to get a plan in place to work around that. And then finally, reporting. Reporting hasn't really changed that much, but I do like this graphic. I think it kind of breaks it down in an easier to read format than trying to read it on CMS. For each category now, you've got different options for reporting. And one thing I will say about quality, even though we're talking about ACI, is that certain measures can only be reported certain ways. So just make sure that when you're selecting your measures, that you pick the measure for which it can be the route that can be used to report it. So for individual reporting, you can still use claims, EHR, qualified registries, QCDRs. Attestation for ACI. Attestation is going to be in the sense that some of these questions are now, they're not thresholds, they're yes, no's, so that will be attestation. Obviously, the ACI category has some EHR improvement activities, so you're going to need to use your EHR if you want to participate in any of that bonus percentages that are available. Still, the qualified registries and the QCDRs are available for that. Improvement activities, same thing. Attestation is going to be really important for this year because CMS hasn't quite figured out how you're going to report that you did these activities if you're not doing them through your EHR. So right now, for 2017, it's simply an attestation, meaning, yes, I did it. You know, I would highly recommend that you do it and don't just say you do it because they will audit. They do audit. And you want to make sure that if you do get audited, you have something to prove that you have implemented such a practice, you know, a workflow change or a new program, whatever your improvement activity is. And then cost is not being looked at this year, but you will still get your administrative claims. And I would highly recommend that you stay on top of those, look at those, because next year that is going to be a part of your overall score. So everything's going to be shifting around. So just make sure you're stay on top of that as well. Those are all the slides that I had on ACI today. I would like to say, I know I kind of mentioned quality, and Stacy mentioned it at the beginning of the webinar. We will keep breaking these down. This time was on advancing care information. I do think that breaking them down helps absorb the information because it's very complex. And if you take it by category, I think you can process it a little easier, at least I can. So we will continue to do these. The next one I'll do, we'll probably go deep either in quality, and then we'll go deeper dive into the improvement activities. But in the meantime, we're here to help you. This is what I do as the Director of Clinical Analytics, is I help practices go in, set up their systems. I help monitor their thresholds. Our team recommends workflow changes and, how can I be better? So if you have any questions, please feel free to reach out to me. My email is on the screen. I'd be happy to, have a discussion with you. And Stacy, I'm all through with my content. I'm not sure if you wanted to open it up for any questions. We've got about 10 minutes left.
Absolutely. So thank you, Carrie. And as you mentioned, I'll open it up. It sounds like we have one question about sending out the slide deck. So Carrie, let me ask you PDF, and then we can send out. Does that
Sure.
work for you?
That works for me.
All right, great. So we will make sure to get the slide deck out to everyone who attended today. Are there other questions that you all would like to ask while we have our expert on the phone?
And of course, if you think of any, you can always shoot me an email.
So I'll give people just a couple seconds just in case. So there was one question about the next webinar and what we'll be covering. So that one is on another category under MIPS, which is quality. And Carrie, did you want to give a little bit of insight into what you might be covering in more detail on that one?
Well, I'm really just going to kind of deep dive into quality and how it transitioned over from PQRS. But then I think I'm going to take a little bit of a stab at sort of talking through some of the larger specialties and what measures might be appropriate or easier to report on per se, and then talk about a little bit about what I mentioned, which is the reporting methods can be different for some of the measures. So we just want to kind of take a look and make sure that whatever you're picking, we're going down the right path.
Great, thank you, Carrie.
Okay, sorry.
All right. So it looks like we don't have any other questions at this time, so we will go ahead and wrap up. And I want to thank you all for attending today, and we hope to see you all in a couple weeks at our next one, which is June 8th, same time.
All right, and thank you guys so much for joining. I really appreciate it.
All right, bye.
Bye-bye.